Good afternoon, everyone. Thank you so much. We are going to move our schedule around a little bit. We do, it's a busy day as we get closer to crossover and many other things. So our members, we have one or two members who are testifying on bills and other committees. We're going to get started today. We're going to start off with the Maryland Health Benefit Exchange, if that's okay. Wonderful. And Victoria, you can begin when you are ready.
Thank you, Madam Chair and members of the committee. My name is Victoria Martinez, and I'll be presenting the budget analysis for the Maryland Health Benefit Exchange. MHBE provides a marketplace for individuals and small businesses to access affordable or no-cost health coverage. As you can see on the first page of the analysis, the fiscal 2026 allowance increases by $31.6 million, or 4.6%, for a total of $718.7 million. Exhibit 1 on page 3 provides an overview of the agency's spending. Most of the agency's budget, about 83%, goes towards reinsurance payments, and 4% goes towards the young adult subsidy program. The remainder of the budget includes 6% for information technology and 7% for administration expenses. And the breakdown of these expenses are shown on Exhibit 2 on page 4. Exhibit 3 on page 5 shows what is driving the $31.6 million increase. The largest change is a $30 million increase for payments within the reinsurance program. In terms of personnel, that's discussed on page 7. There are 6 new regular positions in the fiscal 2026 allowance. These positions support consumer assistance and were brought in-house from MHB's Consolidated Service Center. Considering the fiscal outlook and that these positions are funded in fiscal 2025 using available resources, DLS recommends reducing operating expenses by $267,000. Moving on to the first key observation on page 8. This discusses the reinsurance program and forecasted funding. The reinsurance program was established in 2018 to address rising health insurance premiums, and MHBE receives federal pass-through funding to support the program. Exhibit 4 on page 9 shows sample monthly premiums. Premiums continue to increase for 2025, but they remain significantly lower than prior to the program's implementation. Exhibit 5 on page 10 shows the average premium change, showing that yearly increases in premiums have also decreased since the program's implementation. Exhibit 6 on page 11 shows the actual and estimated reinsurance costs and federal pass-through allotment. Total costs in calendar 2023 were about $59 million more than in 2022. In 2026, reinsurance costs and federal funding are expected to decrease due to fewer people qualifying for an advanced premium tax credit with the end of the enhanced federal subsidies. Exhibit 7 on page 12 provides an update on the estimated closing fund balance of the federal pass-through dollars and state provider fee, showing a high enough balance for program solvency through the end of the waiver period in 2028. The second key observation begins at the bottom of page 12 and discusses the young adult subsidy program. Legislation created the program for 2 years for 2022 and 2023, and the program was extended through 2025. MHB submitted a report on the program in December 2024, which found that the pilot program increased young adult enrollment and reduced the uninsured rate among young adults. Exhibit 8 on page 14 shows enrollment in a health plan by age, showing that enrollment increased in all age group categories. Fiscal 2026 includes $26 million for the young adult subsidy program. Considering that the subsidies are only authorized for half of the fiscal year, DLS recommends adding language that makes $13 million of the funding contingent on legislation that extends the subsidies. Key observation 3 begins at the bottom of page 14 and discusses enrollment in a qualified health plan through the Maryland Health Connection. Exhibit 9 on page 15 shows that there was about a 16% increase in enrollment from 2024 to 2025. The 2025 plan year was the first year that individuals who have a DACA immigration status were able to enroll in a health plan, and 249 DACA recipients enrolled in 2025. The last key observation, beginning on page 16, discusses the findings of a legislative audit of MHBE released in January 2025. 5 of the 8 findings relate to Medicaid eligibility and the MHBE fund, and Exhibit 10 on page 17 summarizes the audit recommendations and MHBE responses regarding these findings. MHBE reported having completed corrective action for 2 of these 10 recommendations, but disagreed with 4 of the recommendations. Finally, page 18 discusses our recommendation. I've already discussed the first and the third recommendation, and the second recommendation is annual language requesting a report on the reinsurance program costs and forecasts. And that's the end of my presentation, and I'm happy to take any questions.
Thank you so very much for your thorough analysis. We appreciate it. Does anyone, Alethea, do you have a question? No? Wonderful, wonderful. Thank you so very much. We will, as we invite the Maryland Health Benefit Exchange up, I would also just like to say we've had a few friends come and want to join us and turned because they couldn't find a seat. I did see Dr. Scalea and others. If you have empty seats next to you, if we could all squeeze in. I know that there's some more folks outside wanting to come in. So if we could just make all available seats kind of clear, that would be lovely. Thank you. Okay, Ms. Eberly, please, whenever you're ready.
Thank you. Good afternoon, Chair Jones and committee members. And for the record, Michelle Eberly, Executive Director for the Maryland Health Benefit Exchange. With me here today is our Deputy CFO, Tishma Delagard. I'd like to thank Victoria Martinez for all the work she has put into this for the last couple of years. She has gathered a lot of information and asked all the right questions to fully understand MHB operations and provide our budget analysis. The MHB team works very hard each year to be effective and efficient with our resources, and I'm privileged to be here today to provide a brief update and answer questions raised in the analysis. The budget you see before you is a reflection of the significant accomplishments the exchange has made since its inception in 2011. I'll remind you that we were established with an annual special fund allocation of not less than $35 million to fully fund exchange administration and operations. The special fund allocation was reduced to precisely $32 million in fiscal year 21, and for the last several years, we have required general funds to fully fund exchange operations and administration. The very large reinsurance fund is strictly pass-through dollars and does not support the exchange administration of operations. So in essence, we have a small budget on which we provide services to 1 in 5 Marylanders. This past year was another hugely successful year. The backbone of our work is Maryland Health Connection, our technology platform, where Marylanders apply for health, dental, vision coverage in both public and private health and plans. I included a link in my written testimony for the 2025 IT roadmap presentation made to our board in January. In this presentation, our CEO relayed many of our accomplishments. I'm going to mention just several of them. Integration of our chatbot Flora with generative AI, enhancing responses for consumers, successfully addressed 650,000 queries. Utilization of robotic process automation to automatically verify Social Security numbers, which reduced 3,000 documents from the human intervention and delay in processing. We enabled our mobile app Broker Connect capabilities for more than 1,000 brokers, allowing our consumers to get contacted by a broker to enroll in a health plan within 30 minutes. And we built a new portal within Maryland Health Connection for hospitals to apply for Medicaid eligibility for deemed newborns. All of our technology developments, and in fact, all the work we do, is looked at through the lens of how can we improve the consumer experience, how can we reduce administrative costs, and how can we achieve better outcomes. Beyond technology, customer service is where we spend most of our dollars. This includes our call center, connector entities, outreach, appeals, and constituent services. Last year, we successfully completed the Medicaid Public Health Emergency Unwinding. It has had a long tail, and our call center is still feeling that pain. However, from an enrollment perspective, we help Marylanders remain either in their Medicaid coverage or enroll in a private health plan. In our February board meeting, we presented a report on 2025 private pay enrollment analysis from our recent end of the open enrollment. We are proud to report that as of the end of January, we have a record new enrollment of nearly 250,000 people. This is the 7th consecutive year of enrollment increases, up 56% since the pandemic, and we saw an 83% increase in enrollees who previously had Medicaid from pre-pandemic levels. The exchange has served as a safety net for Marylanders losing Medicaid. The areas we focus on to spend our marketing and outreach dollars also continue to be successful. Our Hispanic enrollments grew by 25%, our Black consumers grew by 23%, and our young adult population by 21%. While we do exceptional work, we do have challenges. Two areas that have been significantly affected recently are call center and fulfillment costs. These are both directly related to the services we provide for income-based Medicaid enrollment. Before I move on to questions raised in the budget analysis, I will comment on our state reinsurance program. This fund is made up of federal pass-through dollars and a carrier assessment. The carrier assessment for the first year was 2.75% and then reduced to 1% for the remaining years. The reinsurance fund pays a portion of claims for insurance carriers participating in the individual marketplace. This allows the carriers to reduce premiums for all individual market consumers. The exchange administers this fund to stabilize the entire individual marketplace. Should the federal government or the legislature eliminate or remove any of these fund dollars, it will destabilize the entire marketplace for the individual consumers. The state reinsurance program is in place and solvent through December 31st, 2028. Now, on to the budget and the questions that were raised. One, I want to thank you so very much. We're most appreciative of the increase in state PINs for fiscal year 26. We operated with 67 state staff for many years, and we were finally able to add 6 state staff last year for our IT services. With your support, we will add 6 state staff this year for our consumer assistance program. Historically, we have very little turnover at MHBE. We work hard on living our values of diversity and inclusion, innovation, collaboration, and being ethical, and we are rewarded by the longevity of our staff. To answer the specific recommendations, on page 7, DLS recommends reducing operating expenses within MHB by $267,761 in general funds. If you so choose to do this, we will be able to absorb that within our reductions in the call center. We are looking at ways to stay within budget, and that would just be part of that effort of staying within that budget. On page 14, regarding the young adult subsidy program, considering that subsidies through the program are only authorized through calendar year 2025, recommendation is that $13 million of the funding for the program is contingent on the language that extends the availability of subsidies into calendar year 2026. That as well, we are fine with that. I will just note that Senate Bill 5 and House Bill 297 have both passed their committees and their chambers and are ready to move to the opposite chamber. And that extends that program. That's just an FYI. And then the final recommendation is that MHB should provide an update on any additional corrective action taken since the audit was published in January 2025 and how we work with MDH to ensure that we are following MDH policies and federal regulations regarding eligibility determinations. And as Victoria mentioned, prior to OLA publishing the audit, we had corrected finding 2, finding 4, and finding 5. And finding 1 and 3 are both related to Medicaid eligibility and remain open. The MHB leadership team, our policy, compliance, operations, and IT teams all work very closely with MDH daily on implementing Medicaid policy. We also utilize our designated attorney generals with policy interpretation. MDH provides policy positions and Medicaid eligibility requirements, and MHB implements those policies and requirements. And finally, our MHB's internal compliance team conducts internal reviews to ensure the policies are adhered to. Thank you again for this opportunity to discuss our fiscal year budget, and I am happy to answer any questions.
Thank you so very much, Ms. Eberly. I do have a question. I'll kick us off. Page 11. As you get there, it's no surprise that the blue portion is federal pass-through dollars. Questions on federal uncertainty have been a common theme throughout this budget season. I believe it was our first budget hearing that federal funding had unfrozen, frozen again. Before we had adjourned, we're not in here very long. So it seems to be all over the place, and I have a lot of federal employees who are hurting. The rest of my colleagues have federal employees right now who are hurting. Do you believe that the pass-through funding is equally more or less at risk compared to other federal funding? And have you all been making contingency plans, or what does this mean for you?
There are two components that come into play. One is the expanded tax credit, and I like to remind everyone tax credits are just that, it's a tax credit,
right,
like a appliance tax credit, child care tax credit. It was during the pandemic, it was increased, which meant more affordability for health coverage. That expires, that expanded, we refer to it as the expanded tax credit, that expires December 31st of this year. Congress has to take action to extend that. We have been, since last summer, doing an awful lot of education with the federal delegation, with our state delegation, really with the governor's office, really making sure everyone's aware, eyes wide open, what that means, because we anticipate we would lose a lot of enrollments. Now, how that factors into reinsurance is for every person that we have enrolled through the exchange, and is eligible for a tax credit, that increases the funding that gets passed through for the reinsurance fund. So if that expanded tax credit goes away, we anticipate it would impact the reinsurance fund. However, having said that, we have projected out, even without that expanded tax credit, that we could keep the program solvent through the end of the program, which is 2028, providing nothing is taken out of it. That's one thing. The other thing is and the only reason I say this, normally this would not be an issue because Congress has to act on the tax credits. But in this current administration, we have no idea. So the bottom line is yes, whatever funding is cut, as with all programs that we administer, it will result in loss of coverage and other cuts.
Well, thank you for your honesty, and hopefully this is something that we won't have to deal with here. I'm sorry, Delegate McCaskill has a question.
Need to apologize, Madam Chair. Thank you so much. Welcome, everyone. Happy Monday. So I am excited to hear about improving customer service experience. And this has been brought to my attention quite a few times over the past 2 weeks. And so I'm excited to hear about the numbers of enrollment since the beginning of the year, and that transition from Medicaid for many. I'm curious about two things. One, what is the appeals process? Because what I am hearing is that folks got approved for private insurance for the new year, received their billing later on in January, paid their, paid for their premiums, but then by February 1st was terminated, which doesn't make sense to me. And so they went through the appeals process, or is going through the appeals process. However, they have not yet heard from, there's a lag in the appeals process, and these are folks who need their medications, these are folks who need their health insurance. So could you explain to me that whole process of enrolling and what, if you all are experiencing any of these conversations?
I'd be happy to. And first off, we never want anyone to have to get to you. We try and resolve all issues first, and if you do ever get anyone, please send it to me immediately. So that's first off. We had, let me back up. We work with many carriers. We have 5 carriers on the exchange, and that, I'm just talking commercial insurance, not private insurance, or private insurance, not public insurance. So we have 5 carriers in the private marketplace, and we send them files, they send us files, and this is a normal place of how we enroll people. We did find out in January that there was a particular carrier that had sent some erroneous files that terminated a lot of people. And
My folks are especially with United Healthcare.
that was not the one.
Okay.
So with this issue, because it did affect like many people, and we worked with the Maryland Insurance Administration and the carrier, they were all reinstated back to 1/1. The carrier actually picked up the tab for them for January, which was the right thing to do. So those folks all got reinstated. So we have had a lot of complaints about that. We had another carrier whose automatic payment feature didn't work, and so we resolved that. Typically, we have a few of those happen. This year, it seemed to be a little more expanded. I have not heard anything with United Healthcare being an issue. So in answer to your question, how the appeal process works, we have a dedicated team that handles appeals. Within our standards are typically within, I think our service level agreement is 3 or 72 hours. We typically respond within 24 hours. And if it's an appeal, we gather all the information. If it has to go to the Office of Administrative Hearings, we will go there with all the information. But we typically don't have any delay at all. So I'd be very interested in getting more specifics so we could help out with that.
Perfect. If I'm not mistaken, this has been in effect for 2 cases since February, since like February 5th.
Okay.
And so and one happens to be a diabetic, and they are having a very hard time with getting their prescriptions. And so they've had to go through other means to get it. So I'm very curious about, but I had heard several people say that they had applied, then terminated, and et cetera, and I just wanted to get an update on that. Thank you, Madam Chair.
Yes, thank you. Delegate Ruff has a question.
Thank you so much, Madam Chair. And I apologize for missing most of your presentation. So if my question has already been covered, please forgive me and just tell me, shove off, Ruff. I wanted to ask about the audit findings, number 5 and number 6. I know you guys have stated in your testimony that an internal procedure will be completed this month to ensure that this failure to collect the $649 million from MIA would happen, and that the publishing of contract awards and document bid proposals would also be published. I'm wondering, is the $649 million still recoupable? And can you give us more color on what those procedures will be? And the same for finding number 6.
Absolutely. And I mean, it is not a good finding. However, I will say, it is a matter of transferring funds from one state agency to another. So there was never a point where we were not going to get those funds. It was just a mechanical transferring from this account to that account. So that has been taken care of. What we've done internally is put a procedure in place. So if those funds are not in by the date they're supposed to be, then we start an escalation chain to make sure they get there. So that was just a process issue on escalating. And the other one, I think, was I'm sorry.
Contract awards and document bid
Yes,
proposal.
that's already done. So that was, again, when they look at this, they go back in time, and it was from a period of 2020 to 2023, and they found several procurements that had not been posted to our website. And again, that was during that time period and oversight of that not occurring, but we always go back to what does our policy and procedure say, and let's make sure it's in that policy, what the service time is for getting it posted, and then we transfer that to our compliance department who does an internal review to make sure that is occurring. So that has been corrected as well.
Okay, great. Yeah, it's definitely a priority, especially in the Legislative Black Caucus for procurement reform.
Yes.
And just wanted to make sure that that was top of mind.
Right.
It was definitely top of mind as I reviewed this. So thank you very much for your responses.
You're
and thank you,
welcome.
Madam Chair.
Thank you, Delegate. Thank you, team. Madam Vice Chair for a question.
On page 14, Exhibit 8, we just, I wanted to talk about the increased enrollment from 18 to 25-year-olds. It's wonderful to see. So what outreach methods have been used for this age group? And is it the outreach that's proven to be successful, or is it another way that you've been able to reach this group in order to have a 30% increase?
It's been outreach, as well as we introduced a young adult subsidy program 4 years ago. We had a 2-year pilot, another 2-year pilot, and now it's going through to become permanent. And it on average, it's about $38 a month. And when you're in younger, age group, every dollar matters. And so we found really, again, making it affordable made it attractive. So that was one thing, the cost. 2, we've done a lot of targeted outreach and marketing to this group. And so using social media influencers, really tapping into the communities. And what's most important is that in that age group, we saw significant increases in Hispanic enrollments in that age group. So that was tremendous too. So it's an all of the above approach, looking at our marketing, looking at our in-person assisters, working with our stakeholders, the boots on the ground, and then of course making it affordable. And then again, trying to communicate with mothers, aunts, caregivers, how important it is for youth to get health coverage. So all of the above.
Well, congratulations. That's all good news. Thank you so much. And thank you for all that you're doing. Thank you, Madam Chair.
Thank you, Madam Vice Chair. Thank you, team. Appreciate your testimony today. Seeing no further questions from members of the subcommittee, that concludes our budget hearing for the Maryland Health Benefit Exchange. Thank you so much.
Thank you.
We'll now move on to the Office of Home Energy Programs. So we'll start with our DLS analysis presentation by Suveksha Bujal. Thank you. You can begin when you're ready.
Thank you, Madam Chair. I'm Suveksha Bujal, and I'll be discussing the Office of Home Energy Programs. The fiscal 2026 budget increases by $56 million, or 24.1%, to a total of $288.2 million. Exhibit 1 on page 5, we have the energy burden reduction for all fuel sources. In federal fiscal 2023, the average annual energy burden after receiving low-income home energy assistance program benefits was 9.1% for all households and 13.6% for high energy burden households. OHIP benefits reduced the energy burden for all households receiving a benefit by 28.8% and for high energy burden households by 25.8%. Exhibit 2 on page 6 shows the benefit targeting index. The benefit targeting index decreased to 88 in federal fiscal 2023. A benefit targeting index of 88 indicates that households with highest energy burdens saw a 12% lower benefit compared to all households. DHS should comment on the reason behind the decrease in the index in recent years, given that the structure of the benefits has historically been to provide larger benefits to those with lower incomes. In federal fiscal 2023, burden reduction index decreased to 90, indicating that high energy burden households had a 10% lower reduction of energy burden compared to all households. DHS did not include actual data for fiscal 2024 in its annual Managing for Results submission due to concerns about reliability. Additionally, the 2024 Joint Chairman's Report requested DHS to submit a report providing information on the number of applications received, the average number of days to process application, and the number and percentage of applications processed within certain timeframes. The report due on December 31st, 2024 was submitted on February 17, 2025. The report was not submitted in time for inclusion in this analysis. DLS recommends adopting committee narrative requesting data on energy assistance participation rates for vulnerable populations. DLS recommends restricting funds pending submission of a report on energy assistance application processing times and denial rates. On page 7, we have discussion on the proposed deficiency. The fiscal 26 budget contains deficiency appropriation of $30.9 million, $22.2 million is from federal funds, and $8.7 million is from special funds. The proposed deficiency includes $22.2 million from the Low-Income Home Energy Assistance Program, $7.8 million from the Electric Universal Service Program, and $0.9 million for communication expenses. Exhibit 3 on page 8, we have the overview of agency spending. $270.2 million or 94% of the OHIP budget supports energy assistance benefits. Funding for the USB program benefits, including both electric bill payments and arrearage assistance, totals $187.7 million, or 65% of the budget. Funding for Maryland Energy Assistance Program accounts for $82.1 million, or 29% of the budget. Moving on to Exhibit 4 on page 9. As I mentioned earlier, the fiscal 26 allowance for OHIP increases by $56 million, or 24.1%. Which is primarily due to an increase of $55.6 million in the Strategic Energy Investment Fund revenues allocated for energy assistance. On page 10, DLS is asking DHS to comment on if they anticipate any additional supplemental funding through the LIHIP allocation. On page 10, we also have discussion on the Electric Universal Service Program. Public Utilities article sets the annual amount of USB ratepayer surcharge revenue collections at $37 million. However, $49.3 million is budgeted in fiscal 26 allowance, approximately $12.3 million more than the annual maximum collection amount. Including the deficiency appropriation of $11.2 million, USB ratepayer surcharge revenues total $49.6 million in fiscal 25. DHS reports that the funds in excess of the maximum collection amount was an error. DHS should comment on how they plan to cover the costs associated with the deficiency appropriations, given the funds are not available. DLS notes that given the increased caseloads, the reduction in USB allocations should come from administrative expense instead of energy assistance programs. On page 11, we have discussion on the Strategic Energy Investment Fund. The state government article requires at least 50% of the revenue received by the state from participation in the Regional Greenhouse Gas Initiative Program auctions be directed for energy assistance. Exhibit 5 on page 12, we have the REGI auction revenues. Total REGI program revenues received by Maryland from all auctions held during fiscal 24 totaled $214.2 million, which is the highest yearly revenue in program history. Exhibit 6 on page 14 provides a historical summary of the annual levels of CEF funds budgeted for energy assistance through OHEP. The fiscal 26 allowance includes $150 million in CEF funds, an increase of $55.9 million. Exhibit 7 on page 15, we have the estimated energy assistance portion of the CEF fund balance. Despite increased spending of the CEF for energy assistance benefits in fiscal 26, the anticipated closing balance totals $59.1 million. DHS should comment on its plan to use the fund balance. Moving on to the first issue, starting on page 16. Exhibit 8 shows the energy assistance benefits history. The number of applications for energy assistance increased by 61.1% in fiscal 2024, which can be primarily attributed to Chapter 207 of 2023. Chapter 207 raised the annual income eligibility level for USP to 200% of the federal poverty level. Chapter 207 also revised the criteria for household eligibility in all OHEP assistance programs to establish categorical income eligibility and automatic enrollment for households receiving benefits from the Supplemental Nutrition Assistance Program, Supplemental Security Income, Temporary Assistance for Needy Families, or Means-Tested Veterans Affairs benefits. Although the applications for assistance programs increased significantly from fiscal 2023 to 2024, this trend does not apply for the number of households receiving benefits. Only USP recipients experienced an increase by 22.1%. In April 2024, funding for MEEP and the Gas Arrearage Assistance Program was exhausted, and DHS stopped issuing new benefits under the program. This suspension of issuance of benefits contributed to the decline of recipients for both MEEP and Gas Arrearage Assistance. Exhibit 9 on page 18 shows the energy assistance applications and benefit data. Through December 2024, fiscal 25, applications for energy assistance have increased compared to application during the same period in fiscal 2024. These increases indicate continued high demand for energy assistance in fiscal 25 as energy prices have continued to increase through the first half of fiscal year. Consistent with the higher number of applications, the number of households receiving energy assistance benefits has also increased for all programs except for our gas assistance program. DHS should comment on the decline in number of households receiving gas assistance despite the increase in applications in fiscal 25. Total benefits paid in fiscal 25 has decreased by $48.6 million or 49.5% compared to benefits paid during the same time period in fiscal 24. Although a decrease would be expected given the decline in benefits amount, the significantly lower benefits compared to fiscal 24 could indicate that not all funds budgeted for benefits will be used. DHS should comment if it is considering a supplemental benefits if excess funds remain at the end of fiscal 2025. On page 19, we have discussion on the implementation of the categorical eligibility. Committee narrative in 2024 JCR requested that DHS provide an update on the status of implementation of categorical eligibility for energy assistance programs. Exhibit 10 on page 20 shows the number of households with income between 175% and 200% of the federal poverty level that were served because of income eligibility changes implemented by Chapter 207, as well as categorically eligible households above 200% of FPL receiving benefits. Exhibit 11 on page 21, we have the average benefits paid in fiscal 2024 and 2025. OHEP reduced the benefit amount in fiscal 25 for the bill payment programs to accommodate the increased number of eligible households within the available funding. Starting in fiscal 2025, OHIP has restructured the categories that it uses to determine benefit levels, resulting in highest benefit levels being provided to smaller groups. Exhibit 12 on page 22 shows the comparison of benefit levels between fiscal 2024 and 2025. Exhibit 13 on page 23, we have the average benefit size for bill payment assistance program. In fiscal 2024, average benefit for MIP decreased by 33.1% and USP benefit assistance decreased by 13%. In fiscal 25 through December, the average benefit for MIP program further decreased by 74.3% and the average benefit for USP bill assistance program decreased by 59.9%. DHS should comment on the impact of these benefit changes given the higher utility cost and prolonged cold weather. Issue 2, starting on page 24, we have the customer service availability for energy programs. Committee narrative in 2024, JCR requested that DHS provide a report on customer service availability for energy programs. DHS provided customer service assistance to energy benefit applications through the staff of local administrating agencies and the DHS call center. Due to the absence of proper tracking measures, DHS was not able to provide data on response time, voicemail statistics, abandoned call, and the number of inquiries made in person or via email specific to the energy assistance inquiries. In absence of energy assistance specific call center measures, DHS should discuss the overall performance of DHS call centers on these metrics. In the report, DHS notes that the system-wide challenges led to DHS pausing benefit payments in April 2024. DLS notes that DHS had, until this report, previously described the pause in MIP benefits as being due to exhaustion of funds. If the reason was due to system-wide challenges, it is unclear why DHS initially reported the pause as related to funding or why the pause would have only impacted 2 federally funded programs. DHS should clarify the reasons for the pause and change in explanations. Starting on page 25, we have the operating budget recommended actions. The first recommendation is to reduce general funds for miscellaneous personal expenses. Recommended action 2 restricts fund pending submission of a report on application processing time and denial rates. Recommended action 3 reduces special and federal funds associated with communication expenses in fiscal 24 to level with fiscal 24, in fiscal 26 to level with fiscal 24 actual expenditure. 23 million of the fiscal 26 allowance was labeled as an expense for a call center. DHS has indicated that was an error. The language in recommended action 4 restricts the use of that fund for energy assistance benefits to ensure the funds are used for the intended purpose. Recommended action 5 requests MFR data for fiscal 2024 and 2025. Recommended action 6 reduces special and federal funds associated with communication expenses in fiscal 25 to level with fiscal 24 actual expenditures. This concludes my presentation, and I'll take any questions you may have.
Thank you so much. Any questions from the subcommittee? Delegate McCaskill does not have a question. No problem. It's Monday for all of us, you know. Thank you so much for your thorough and thoughtful analysis. We'll now bring up our OHEP team from DHS. Please make your way to the table, and you can begin when you are ready.
Good morning, Chair Shetty and members of the subcommittee. For the record, I'm Carnitra White, and I serve as the Principal Deputy Secretary for the Department of Human Services. We're grateful to Ms. Vudajel for her budget analysis. And joining me at the table is our Executive Director for Family Investment, Augustin Nabaganamani, as well as Courtney Thomas Winberg, who is our Acting Director for the Office of Home Energy Programs, and Jessica Smith, our Acting Chief Financial Officer. While you have our written testimony, I would like to highlight a few items and then address the issues in the analysis. The Office of Home Energy Programs provides energy assistance to Maryland households through a network of local departments of social services, community action agencies, and municipalities. 2024 was a year of rebuilding the OHEP program. During last year's legislative session, we informed you that we plan to visit each OHEP local administrating agency to learn about the work on the ground and hear directly from our partners and how we might best support them. And we did just that. We conducted 20 visits. The LAAs, it is Monday for everybody, told us about operational and resource challenges that significantly impacted their ability to serve those seeking energy assistance. These issues included a lack of communication and consistent guidance from our office. We also learned the local impact of the 2024 implementation of categorical eligibility, which significantly transformed the energy assistance process and ensured access for Marylanders who were eligible for the service. By automatically considering households receiving SNAP, supplemental security income, temporary assistance for needy families, and mean-tested Veterans Affairs benefits. In 2024, we received 243,252 applications. This is over 100,000 more applications than we received in 2023. Local OHEP offices were unprepared for this surge in applications, and misalignment between system capabilities and operational processes made these challenges worse. These issues led to significantly longer processing times, delays in benefit issuance, and early exhaustion of federal funds. We listened, we learned, and as a result, we took strategic actions to address the challenges and enhance the OHEP operations. These actions included upgrading technology and expanding system access to equip local agencies with the necessary tools for efficient application processing. Just as an aside, I personally delivered on these visits scanners to the LAAs because they just didn't have the basic tools that they needed. Providing comprehensive training and standardizing process across local offices to improve consistency and efficiency. Implementing system enhancements to automate key functions, allowing staff to focus on more application processing, and expanding DHS customer relation management tool to all OHEP offices, enabling the agencies to receive work orders and handle customer inquiries directly. We also adjusted benefit levels to serve as many Marylanders as possible, and we increased communication with our local OHEP offices and stakeholders. And lastly, we changed OHEP staffing and leadership. And I'd just like to take a moment of privilege to thank our acting director, Courtney Thomas Winberg, for her leadership. She also serves as the local director in Allegheny County Department of Social Services, but Courtney has come in and stepped up to serve in this role as the acting director of OHEP. In her previous experience, she ran a LAA, and so she had the credibility and the knowledge to help us discover the challenges as well as put in solutions to begin to resolve those challenges. So thank you, Courtney, for your leadership. Based on these efforts, we have improved program operations, reduced processing delays, and lowered application denial rates. While in state fiscal year 2024, our percentages of applications approved each month were lower than 40% for the final quarter of the year, far above historical averages of above 60%. Now, those historical averages in 2025, year to date, are 74% approved applications. Similarly, our denials rate spiked in 2024, reaching above 50% for both MEFAP and EUSP. The denial rates now are at historical lows so far in 2025, below 25%. You'll see in our written testimony charts demonstrating these trends. We recognize that we still have much more work to do, and we will continue to stabilize our OHEP operations, expanding access to energy assistant benefits. Our focus will remain on strengthening capacity at both the local and the state levels. We're committed to deepening our partnership with our local administrating agencies, and for the first time in 4 years, increasing program budgets to enhance service delivery and meet the growing needs. Now we'll turn to the responses and the analysis, and my colleague Courtney Thomas Winterberg will address the first two issues.
In response to DLS's request that we comment on the decrease in benefit targeting index, in fiscal year 25, we implemented a revised benefit structure to ensure that households with the lowest incomes relative to household size received the highest level of assistance. MEEP grants are determined based on the household's primary heating fuel type and income level relative to household size. The EUSP grants are calculated using multiple factors, including the average kilowatt-hour cost in Maryland, the household's primary heating source, income level relative to household size, and the household's electric usage over the prior 12 months. These calculations follow a flat rate benefit model, enabling OHEP to more accurately predict expenditures and efficiently manage our benefit allocations, ensuring that assistance reaches as many Maryland households as possible. This targeted approach enhances the support for our most vulnerable families with the greatest energy burden to maximize the program's impact. In response to DLS's recommendations that DHS provide data on energy assistance participation rates for vulnerable populations, we concur.
Good morning, good afternoon. In response to DLS question, does DHS anticipate any additional supplemental LAHEAP funding found on page 10? Pending any additional federal action, we do not anticipate receiving additional LAHEAP funds. OHEP will continue to maximize available resources to support eligible households within the existing funding allocation. In response to the question, our fourth comment, does DHS plan to cover costs associated with the deficiency appropriations? We will monitor administrative expenses such as postage and will take steps to adjust for the costs within the limitations of our spending cost allocation plan. In response to number 5, DHS plans to use the Energy Assistance Fund balance found on page 14 of the analysis. We are currently reviewing our options, including supplemental benefits, and will provide an update at a later point.
In response to DLS's request that we comment on the decline in the number of households receiving gas arrearage assistance despite the increase in applications, households are eligible for gas arrearage benefits once every 5 years unless they qualify for a vulnerable population waiver, which is applicable to households with a member who has a child 2 years of age or younger, or an adult 60 years of age or older, or has a critical medical need, up to the maximum benefit. In fiscal year 2025, OHEP reduced the maximum gas arrearage benefit to $1,000 to reallocate more funding towards MEEP benefits, ensuring that broader assistance to households facing ongoing energy costs were available. As of February 20th, 2025, the fiscal year 25 GARA deny rate shows that out of the 16,314 denied households, 55% did not meet the minimum past due balance requirement of $300, while 38% have previously received the gas arrearage benefit within the last 5 years. In response to whether DHS is considering a supplemental benefit if excess funds remain at the end of fiscal year 25, DHS is actively monitoring MEEP and EUSP application trends and expenditures. We will review our options and provide an update at the appropriate point in 2025. We always want to ensure that Maryland's receive the maximum extent of benefits possible for available energy assistance funds, including through supplemental grants. In response to DLS's request that we comment on the impact of the benefit changes given the higher utility costs and prolonged cold weather. As mentioned previously, we are actively monitoring MEEP and USP application trends and expenditures. We always want to serve as many Marylanders as possible, especially those who need it most with our available funds. This winter, we introduced a new crisis benefit. We will also maximize our partnerships through local customer referrals, through the Fuel Fund and Dollar Energy, and work with every one of our local partners to ensure Marylanders receive the help that they need.
So in response to the issue regarding the call center measures and in relations to the OHEP offices, as I mentioned in the testimony, we have expanded our customer relation management tool to all of the OHEP offices so that we will have better reporting mechanisms as we move forward. And since the launch of our new call center in August 2024, we have been working with the vendor and we have certain data points. We're adjusting our call center, as I said, so that we can include the energy assistance specific tracking, and we'll have that information, more refined data in 2025. Overall, for the call center, in our preliminary analysis of the calls that were answered by the energy assistance queue, 21,240 were verified to be customer service center representatives as an inquiry for the OHEP program. And overall, for our call center since August 2025, we've received nearly 1 million calls, of which the answer rate is 58% with an average wait time of 18 minutes and 14 seconds. As I mentioned, we're working with our call center in order to decrease the wait time and increase the answer rate. We've been doing that over the last few months. So in comparison, this month, the call center has an answer rate of 87% with 83,000 calls answered and 12,000 calls abandoned with an average wait time of 6 minutes and 17 seconds. And from last week, the average call average calls answered was 98% and the wait time of 41 seconds. So as you can see, we're having some progress as we're looking at working with our new vendor, and we will continue to work with them to make sure that we are making sure Marylanders have the customer service that they deserve and that we are meeting the required call answer time within our contract, which is 30 seconds of 90% of all the calls. Also, just to clarify, regarding the pause in benefits in 2024, as we've stated, the reason for the pause in benefits last state fiscal year was due to the exhaustion of funds. As I mentioned in our testimony, we received a record number of applications, nearly 250,000 applications for energy assistance, and the increased demand, as well as a return to pre-pandemic funding levels, and it has and the increased demand for assistance impacted the amount of families that we could help in 2024. And I'll turn it to Jessica to respond to the recommended actions.
In regards to the recommended actions, beginning on page 25, we concur with recommended actions 1, 2, and 4. We also concur with recommended action number 5, but note that the fiscal year reporting interval should be federal and not state fiscal year. Recommended action number 3, to reduce fiscal year 2026 special and federal funds associated with communication expenses to level with fiscal 2024 actual expenditure. We respectfully disagree in part. These fiscal year 2026 funds are necessary to ensure the required mailings are sent to beneficiaries. Expenditures for these costs were also reported in the Family Investment Administration budget in fiscal 2024. The expenditures shown in the OHEP budget in fiscal 2024 do not reflect the full cost of postage. DHS requests that federal funds of $440,096 associated with communication expenses be included in the fiscal year 2026 budget. Recommended action number 6, reduce fiscal year 2025 special and federal funds associated with communication expenses to level with fiscal 2024 actual expenditure. We respectfully disagree in part. for the same reason stated in the fiscal 2026 funds.
And then lastly, we want to note that the energy assistance processing times and denial rates report, as mentioned, was submitted late. We do apologize for that and apologize for the late reports. I've been working with my team and talking to my team about ways for us to make sure that we have reports submitted timely in 2025. And Chair, with that, that concludes our testimony, and we're happy to answer any questions that you may have.
Thank you. Thank you, Principal Deputy, Monday. Principal Deputy Secretary White, thank you and your team for your incredible work. This is a program that is extremely important to some of our most vulnerable Marylanders. It's one that I know has had many, many significant challenges for many years, and hence the report language request for updates on how things are going. And so really appreciate hearing some of the big progress that you've made specifically on the call center. That has been, an incredible sore spot for a number of participants who wish to enroll in the program, and not being able to access a live person who can help them is really frustrating. And so thank you for your continued work on that. I just wanted to say that before I turn the mic back over to Madam Vice Chair to chair the remaining part of the hearing. I have to go up to rules for the time being, but it's always great to see you, and I look forward to our continued partnership. Thank you.
Thank you, Chair Shetty.
Thank you, Chair. Delegate McCaskill.
Thank you so much, Madam Chair. So, Carnitra, you know I like flow charts to help me understand things better, and maybe this will, during the interim, be a walkthrough, another walkthrough for me. However, in the meantime, while I have you here, forgive me, what's your name again?
Courtney?
Courtney.
Welcome.
Thank you.
And so I too am excited to hear about all the internal changes that affect the customer service because, of course, when they can't get you all, they call us. And so I have two questions. One is about seniors, and the other is about your comment on appropriate time point when it comes to responding to the comment about supplemental benefits access fund remain at the end of the year, like what your plans are for that. When you say the appropriate time for 2025, is that when about could we expect some kind of reporting around the access funding and what your plans?
Yeah, so we are currently reviewing that, and so we are, I think, probably around the third or fourth quarter of the year, we'll be able to have better, the beginning of between the middle and of the third quarter and beginning of the fourth quarter, we'll have better assessment of what our actual spending has been, what the expenditures have been, and whether or not we can provide supplemental benefits.
Perfect. My last question has been a concern for our seniors. We usually don't get to go out and visit, go out of the session to go back into our communities to have meetings, but I was fortunate enough to have a meeting with our seniors last week. And their concern has been energy assistance. And so, of course, so it's really exciting to hear about the internal changes because their concerns were by the time they apply, and they don't either have the necessary documentation or they don't maneuver correctly within the system, the funds have been exhausted. And so are there any parameters for seniors or any vulnerable communities that need more assistance outside of, like, I don't know when you have an application, it's online, or you also mail the application. What's that process for folks?
So I'll let Courtney take it, but I'll just want to say a couple of things first before I let Courtney, who is the SME in this. One, I think we made it a lot easier for seniors through our categorical eligibility.
Okay.
Right? So seniors who receive SNAP will automatically be eligible for the benefit, and us doing more outreach so that they understand that. They don't have to apply. They will be automatically enrolled. They may need to give us information about their electrical benefit provider. And then once we have that, every year, if they're still receiving SNAP, they will be automatically enrolled into the program. So I think that is one way that we are streamlining and making it simpler for many vulnerable populations, including seniors.
Okay.
And then I'll let Courtney.
Sure. So for a couple years now, we have actually been mailing redetermination packets to seniors who are on a fixed income. They go out 4 times a year, so they're getting a simplified application that they just need to sign and return. It comes with a postage-paid envelope. So that's one way we're able to assist seniors. Deputy Secretary White is correct. Categorical eligibility has truly streamlined application processing for everyone. I think prior to fiscal year '24, the largest denial reason was related to incomplete information, and most of that around paperwork being returned or paperwork being returned with the correct dates. So local processing agencies now, even if an application comes over from the enrollment and eligibility system, they're processing those as categorical eligible. But if they get a paper application or an application that comes through the consumer portal, the first thing they're supposed to do is to verify whether or not that customer also qualifies as categorical eligible, and if so, to process that way.
Okay.
And then just a common misconception, I think, that's been in place over the years with the network is that people do not need to come into the office or apply over the internet for energy assistance. All of the local offices are equipped to do telephonic applications, and then we do have provisions in place with all of the LAA contracts that allow the local staff to go out to the home or a community center to assist if someone needs additional assistance applying.
Perfect. So indeed, I'll probably need that walkthrough or that or that flow chart so that we can help guide as well. Thank you for your comment, Madam Chair. Thank you.
Thank you so much. I just want to make sure, I was making a note at the same time that potentially you were addressing this, so let me just ask, and I apologize if it was. The JCR report, did we address this?
Yes, I apologize for it being late. We submitted it on February 17th, and I've been working with my team to make sure that we get all of our reports on time in 2025.
February 17th, fantastic. Just wanted to follow up on that. I apologize. I was writing a note and you were
And
saying
it's Monday.
My second one was on page 9. Often, this is the same question. Federal funds increased by approximately $1.6 million, primarily due to increase in LIHEAP program funding. So this is, how comfortable are we right now with any portion of the budget coming from LIHEAP? What are the contingency plans? What happens if funding starts to dry up at the federal level?
So far, we haven't had any problems doing our federal drawdowns. And what we understand, and my team will correct me if I'm incorrect, at this point, we haven't had anything that there will be any cuts to the program that provides direct benefits to persons. So that's where we stand now. As always, we continue to plan and to look and to monitor information coming from the federal government in these times and in constant conversations with our federal partners in our regional offices so that we can be aware of any potential impacts that will have on Maryland.
Thank you so much. And does anyone else have a question? No? Well, thank you so much. This program is so critically important to so many Marylanders. I thank you for your work, and we can move on.
Thank you. Thank you all for your continued support.
All right. That concludes Office of Home Energy Programs, and we will now move on to MDH Health Regulatory Commissions with Ann Braun. And Ann, as soon as you are ready, go ahead. Thank you so much.
Thank you very much, Madam Chair, members of the committee. Today, I'm presenting the budget analysis for the Health Regulatory Commissions under the Maryland Department of Health. This includes 3 independent offices, the Maryland Healthcare Commission, HSCRC, the Community Health Resources Commission, and it also includes the Prescription Drug Affordability Board. Jumping right into page 2, this begins the budget discussion and covering items related to fiscal 25. $1.5 million in general funds was added by the General Assembly, but cost containment actions approved by BPW in July reduced this funding by $375,000. After accounting for this reduction, $750,000 was provided for a grant to the Maryland Patient Safety Center to develop a public awareness campaign for healthcare workplace violence. An additional $375,000 was budgeted under HSCRC to be distributed to CRISP for services from Dr. First. MDH and the commissions are asked to provide an update on how much has been spent of these funds year to date. Covering proposed deficiencies, there are 2 that add a net $21.5 million for the Shock Trauma Center, as $3.7 million in MEMSOF support is withdrawn, but $25 million in special funds collected through the increase in the vehicle registration surcharge is added to the budget. Moving on to the fiscal 26 allowance, Exhibit 1 shows the largest components of fiscal 26 spending. Just under $50 million, or 16%, is paying for personnel and operating expenses that are supported with user fees, and the bar to the right shows that HSCRC accounts for the largest share. Beginning in fiscal 26, the maximum cap in user fees that HSCRC can collect will be reduced. However, HSCRC indicated this lower cap would not be enough funding to support its projected expenditures next year. And so there are departmental bills introduced this year that would instead allow for a higher cap, and that would provide approximately $1.6 million in additional user fees. That amount is assumed in the allowance, and so it should be noted that failure to pass the departmental bills would result in a shortfall in the HSCRC budget. Starting on page 4, the next exhibit shows the proposed budget changes. I'll highlight just the largest increase in fiscal 26 is $17 million for the Maryland Trauma Physician Services Fund. That receives more funding from the increase in the vehicle registration surcharge. Partially offsetting this growth is a decrease of $15 million as the mandate for the Health Equity Resource Community, or HERC, grants ends in fiscal 2025. On page 6, there is a discussion on the Maryland Patient Safety Center grant. Beginning in fiscal 24, there is a $1 million mandate for the special fund that supports the Patient Safety Center. However, a provision in the BRFA would repeal the mandate beginning in fiscal 26, and the budget reduces $1 million in general funds contingent on this provision. Moving on to the key observations section, the first begins on page 8 and has to do with the Consortium on Coordinated Community Supports within the Maryland Community Health Resources Commission. This consortium was created as part of the blueprint to meet student behavioral health needs. Exhibit 3 shows the mandated funding levels for consortium grants and as proposed in this year's BRFA. A provision in the BRFA would reduce the mandate by $90 million on an ongoing basis, beginning in fiscal 26. And the budget as introduced includes a contingent reduction of that amount to level fund the program at $40 million. The next section discusses a provision in the 2024 BRFA that expanded the use of consortium funds to reimburse MDH for the state costs of school-based behavioral health services that are covered by Medicaid. Fiscal 2025 budget bill language limits that use to no more than $12 million. Medicaid previously only covered school health services that was required for students with IEPs. As of January 1st, 2025, MDH expanded Medicaid coverage to now include services provided by certified school psychologists and social workers for any Medicaid-eligible students. It's estimated that $8 million in consortium funds will pay for the state share in fiscal 25. After accounting for that spending and then about $25 million in prior year funding that was carried forward for future use, this would mean that $57 million in consortium funding would be available for grants in fiscal 25. Turning to Exhibit 4 on page 11, this shows consortium grants by local jurisdiction, and it shows that there are $109 million in active grants approved through the end of fiscal 25. These grants support prevention, early intervention, and treatment, and are reported to serve more than 143,000 students. $89 million of this grant funding was expected to be distributed through this month, and MCHRC is asked to provide an update on the funding distributed, including whether any remaining funds are expected to be carried forward at the end of fiscal '25. The Community Health Resources Commission is also asked to discuss whether the estimated children served would not otherwise have received services, or if they would have been served but through another funding source. Based on the grant funding and students served, the per student amount varies greatly across jurisdictions, as it ranges from $144 per student in Allegheny County to over $2,600 per student in Worcester County. Considering this wide range in provider costs, DLS questions the efficiency of the consortium grant process. The consortium's most recent request for proposals for another round of grant funding closed earlier this month, and awards are expected to be announced in April or May for the fiscal '26 grant period. Moving on to the second key observation, this has to do with the state's preparation for the AHEAD model, which is a new federal agreement with CMS that will begin in calendar 2026, and it builds on the current total cost of care model. Both models continue the all-payer hospital rate setting system, and they seek to control growth in healthcare costs and improve population health. The AHEAD model will include targets for limiting cost growth across all payers and targets for primary care investments. Appendix 2 provides Maryland's results under the total cost of care model in recent years. The next discussion is on the Maryland Primary Care Program, which offers federally funded incentives to primary care providers to deliver advanced services. Exhibit 5 on page 14 shows the Hilltop Institute's analysis on the cost effectiveness of this program. Hilltop found that the program's results range from a net cost of $18.3 million to savings of $342 million. And so this suggests that the program was largely cost neutral or led to net savings. Under the AHEAD model, there would be multiple new primary care initiatives, including a new advanced primary care program under Medicaid that is planned to start in July 2025. Another BRFA provision would establish a special fund with hospital rates assessed by HSCRC to pay for that program. The Medicaid primary care program will operate similarly to the existing Maryland primary care program by distributing additional per member per month care management fees to participating providers. The department is asked to comment on whether managed care organizations, or MCOs, would retain the savings from this advanced care, or if these savings would be shared with the state. DLS also recommends requesting continued evaluation of the cost effectiveness of the Maryland Primary Care Program and to provide status updates on the new primary care initiatives. But I will note this recommendation appeared in the Medicaid analysis. Moving on to key observation 3, this covers recent legislative changes to state funding for trauma centers. Some trauma center costs are covered through hospital rate setting that's regulated by HSCRC, but other costs like on-call physician rates fall outside of that authority. A commission established through 2023 legislation was tasked with assessing the adequacy of state funding for trauma centers. Legislation passed last year implemented some of the commission's recommendations, such as increasing the vehicle registration surcharge and then distributing more of this revenue to the center, or I'm sorry, to the Shock Trauma Center and the Maryland Trauma Physician Services Fund. The legislation also required 20% of fines from certain driving offenses to support the Maryland Trauma Physician Services Fund. The legislation also altered the reimbursement methodology under that fund and allows more flexibility to MHCC and HSCRC to make changes to how that fund is administered. For the Shock Trauma Center, MEMSOF support was discontinued in fiscal '26, while there was also additional revenue from the vehicle registration surcharge that's added to the budget. However, there's been conflicting information in the budget books regarding the amount the shock trauma is expected to receive from that distribution. And so DBM and MHCC are asked to clarify the correct amount that should be distributed to the Shock Trauma Center. Budget bill language in fiscal '25 restricts funding from HSCRC pending a report that evaluates the recommendations from the commission. And so pages 17 and 18 summarize HSCRC's response. The report found that actual trauma costs were $44 million higher than regulated rates, but this was driven by outliers reported by 3 hospitals. Considering the significantly higher costs at those 3 hospitals, HSCRC reported that it would conduct 2 audits on that focuses on trauma costs. And so the commissions are asked to provide a timeline for conducting these audits. Otherwise, HSCRC indicated that trauma centers are not underfunded since they maintained positive margins under their global budget revenues. But HSCRC also noted that hospitals could submit a full rate review request to assess their rate adequacy. DLS found this report to comply with the budget bill language and therefore recommends the release of the withheld funds for HSCRC. And so DLS will process a letter to that effect if no objections are raised during these budget hearings. Key observation 4 begins on page 18, and it discusses the Prescription Drug Affordability Board's recent activity. The board is authorized to conduct cost review of drugs that may cause affordability issues, and then would draft a plan of action with criteria to set upper payment limits for drugs purchased by state or local government and the Medicaid program. In March 2024, the board referred 8 drugs to the Stakeholder Council to consider for cost review, and 6 drugs were selected, and so those are noted on page 19. Most recently, the board received approval from the Legislative Policy Committee in October 2024 for an upper payment limit action plan, and that defines a policy review process, and the board is still updating regulations to match that approved plan. Page 21 shows the DLS recommendation, which is to concur with the governor's allowance. With that, I'll conclude my presentation. I'm happy to answer any questions.
Thank you so much, Ms. Braun. Does anyone have questions? Fantastic. Thank you so very much. And with that, we will virtually go to Mr. Crum, Executive Director. I hope that you are feeling better, sir. Thank you for joining us.
Thank you, Vice Chair Jones. I appreciate the accommodations right off the bat for virtual testimony. Our team has been really hard hit by the flu this week.
Well, I hope that you feel better, and by no means does anyone need to come in with the flu ever. So.
Thank you.
Yeah,
thank you. Absolutely. Absolutely. So good afternoon, Vice Chair Jones and members of the committee. My name is John Crum, the Executive Director of the Health Services Cost Review Commission. I will note that Mark Hoffman is there in person. He's our Chief of Budget. He's in the room if needed. Also, special thank you to Ms. Braun for her always thoughtful analysis. I'll start with just a quick overview, and then I'll reserve the bulk of my time for responses to the DLS observations and questions. But basically, the FY25 budget allowance would allow us to continue our core functions, which focus on healthcare affordability, healthcare quality, and health equity. As a top priority, we continue our work very closely with the hospital industry to ensure that we improve healthcare access across the healthcare delivery system. The budget allows us to conduct legislative analyses as well, which have grown over the past few years, including our ongoing work related to facility fees and consumer financial protection. One of our major key projects this year is managing the transition from the total cost of care model to the Advancing All-Payer Health Equity Approaches and Development model, or a HEAD model. The Maryland model benefits the state and its residents through investments in population health, transparency for consumers, and again, supporting state healthcare infrastructure and access to acute care delivery. So I will go to the observations and questions from the DLS analysis. The first question, how much of the $375,000 set aside to Dr. First has been spent? HSCRC serves as a pass-through entity for the general funds earmarked by the General Assembly. And our understanding is that CRISP has not been CRISP has not invoiced HSCRC for those costs, and it's our understanding that Dr. First has not yet entered into a contract with CRISP. So based on that, we don't expect those funds to be spent in this fiscal year. Second, DLS observed that a failure to pass HSCRC's user fee cap bill will result in a budget shortfall. We agree. Senate Bill 229 and House Bill 54 would, excuse me, would remove the sunset on the current formula for calculating the cap on our user fee assessment. If those don't pass, HSCRC would then need to reduce our expenditures to live within the Commission's available special funds revenue. As we said, the budget really just funds our core functions, so we would have to figure out a way to support the policy work that we have on our slate here, as well as the legislative analyses, while meeting our federal obligations. So a reduction in our budget would limit our ability to support all of that work. We also, third, concur with the DLS recommendation that MDH and HSCRC submit a report that contains an evaluation of MDPCP and a status update related to the new Medicaid Advanced Primary Care Program and other primary care initiatives. Next, DLS asked HSCRC to provide a timeline for conducting 2 audits of trauma center costs. We expect that the audits will be completed in the second half of fiscal year 2026. We are working out the audits as we speak. And then finally, HSCRC thanks DLS and concurs with the recommendation to release the $125,000 in special funds based on our submission of the trauma center report. So with that, I'll pause, and I'm happy to answer any questions that you might have.
Thank you so much, Mr. Crum. I also want to invite up to the rest of your panel who's here, Mr. Mark Luckner and David Sharp. Unsure if you all have testimony as well, please.
Sure. Okay.
Just, yeah, if you could move the microphone so we can get you, and that would be great.
Are you ready? Okay, thank you.
Please proceed.
Good afternoon, Madam Vice Chair and Committee. Thank you for having us. My name is Ed Casemeyer. I'm Chair of the CHRC, and I'm with Mark Luckner, our Executive Director. First, we want to appreciate the allowance of the Governor, and we want to thank Ms. Braun for her accurate analysis. I just wanted to give you a quick overview of the 3 things that we're doing right now. Currently, we manage approximately 200 grants with a value of around $176 million. We have 3 programs we're conducting. One is our annual grant we've been doing for about 20 years, which helps to take care of underserved communities. That's around $7 million. Then we have the HERC program, Health Equity Resources Commission, really to have diversity, to help diversity in many communities. We have 12 grants there worth about $59 million. And the one I think we're focused on the most here today is the consortium, which was created in the blueprint plan. There are 25 members on the commission. It's chaired by former Delegate Dave Rudolph, who's done a great job, he and our staff. We've been meeting for about 2 years. We have 25 members, about 6 or 8 cabinet positions are represented there, behavior analysts, educators, physicians, and we were charged with creating a system to provide behavioral health care to every public school student in the state of Maryland, and to have the service available within 1 hour of their residence. We've done that. 80% of the schools in the state have this service now. We've served almost 80,000 children since we started with the program. Everything has kinks, but we think so far we're going pretty well. And we look forward to your questions about the consortium. And with that, I'll turn it over to Mark to answer your concerns.
Thank you, Senator.
Sure. Good afternoon, Madam Vice Chair. Nice to see you again.
Nice to see you.
I'm going to respond to the suggestions from Ms. Braun. But before I do that, just a couple of thank yous. First, I want to thank my chair. He's been chair of the commission since 2021. A lot of rapid growth, so just thank you for that, Mr. Chair. Also with me, Lorianne Moss. She celebrated her 5-year anniversary with me. She's been essentially the consortium director. And then Bob Lally, our CFO. A lot of rapid growth. You know, when I came to the commission, which was 2009, we were a $3 million commission. So it's a lot of growth, and we just appreciate the support of the legislature and asking us to take on these new projects. And in a moment, I'll answer the suggestions by Ms. Braun.
Thank you.
Of course, I want to thank the administration for their allowance, and I'd also thank Ann for her analysis. So turning to the 3 points that Ms. Braun made in her analysis, about of the 120-some million obligated, 72 million has been paid out to date, about 60% of the funds, and we anticipate that the bulk of those funds will be paid out during the grant period, the bulk of them. The second question, from a fiscal perspective, the second question that Ms. Braun raised is, we're now in the middle of fiscal 25, right? Are we anticipating any funds to be carried over in fiscal 25? And the answer to that would be no, because we have, as Ms. Braun put it out in her analysis, we have a current call for proposal on the street. We got back responses last month, and there's 150 million in requests. And so if you add the allowance in fiscal 25, which is about 40 million, you have to back out the 6 million for the Medicaid billing. So you have about 32, 33 million there. Then you have 40 million in the fiscal 26 revenue. So you have just about 70-some million for 150 million requests. So we anticipate that all of the revenue in 25 will be encumbered before June 30th for a grant period that begins July 1. And then all of the revenue in 26 will be encumbered and spent by the end of that year. It appears that there's a lot of excess funding because in the first 2 calls for proposals, we funded a 60-month project out of 2 fiscal years, fiscal 23 and 24. Mm-hmm. The next RFA that we issue, which will be about a year from now, that'll be solely out of fiscal 27 funding. Shall I turn to other programmatic questions raised in the analysis? Okay. You're laughing, that's good. I like, yeah.
Please proceed, yeah.
Okay. The other second point that Ms. Braun raised is the 150-some thousand children that we anticipate over 120-some grantees will serve. Would they be served anyway, essentially, right? Okay, so the pages 170 through 179 of the blueprint bill, which created the consortium, the legislature, and thank you for that, was very specific in how these funds were supposed to be used. You wrote in there that they should not supplant or duplicate other funding. So when we wrote that RFA, we did significant public outreach. We met with a range of stakeholders, our colleagues in the education world, principally local education agencies, Maryland State Department of Education, local behavioral health folks, and we tailored the RFP so communities could draw from a menu of options. And they had to do one thing when they applied for this funding. They had to get a letter of support from the local education agency. And in giving us that letter, the local superintendent was attesting to the fact that the requested grant funding was not already possible in that jurisdiction. So based on that, we feel pretty confident that the bulk of these programs and services would not have been possible if it weren't for the funding provided by the legislature. The third and final point that Ms. Braun pointed out is the vast variances in the cost per student served by jurisdiction. And that's a fair and accurate analysis. Our perspective is that it's not a question of the efficiency of the grant process. It's more a perspective of the wide differences of what local school districts and the communities that they serve need. One jurisdiction pointed out in Ms. Braun's analysis, Allegheny County, they have a single grant for less than $1 million, and they're serving a great number of folks in what's called a Tier 1 initiative, which means it's implemented across a number of schools, and it's a low-cost, high-yield initiative. Other areas of the state needed more intensive services in which case a child might have extensive needs and they're interacting with a behavioral health professional or a counselor or a psychiatrist or psychologist multiple times throughout the course of the program. So yes, there are vast variances across the different programs served, but we think the most important thing, as Chair Casemeyer pointed out, look, in less than a year, 80% of Maryland schools now have services. That's kind of a big deal. And of the 150,000, 143 to be precise, that are going to be served in a 60-month period, 80,000 are being served. That's a big deal. So we're comfortable with where we are in the implementation of these grants, and with that, I would be happy to answer any questions.
Fantastic.
Shifting gears. Okay. Good afternoon, Vice Chair Jones and distinguished members of the subcommittee. I am David Sharp, the director at MHCC's Center for Health Information Technology and Innovative Care Delivery. As you know, Mr. Ben Steffen, MHCC's executive director, will be retiring on April 1st and is on leave until then. During his leave, I had been designated as acting executive director. The MHCC would like to thank the governor, the Department of Budget Management, and the budget committees, and the Department of Legislative Services for its thorough budget analysis. We also appreciate the guidance provided by Ms. Braun throughout this process. Additionally, I would like to recognize Ms. Tracy DeShields and Mr. Richard Proctor, who were to my right, who were instrumental in helping us develop the budget for this year's process. You have our PowerPoint presentation, and I don't plan to go through it in detail. However, I would like to draw your attention to the notable accomplishments on slide 11 and 12, which highlights several key achievements by the MHCC over the last year. To provide some context, MHCC is an independent regulatory commission with 15 commissioners focused on evaluating, regulating, and influencing the healthcare systems. The MHCC leverages data, public reporting, planning, and regulations to improve quality and reduce cost and enhance access. I will now respond to Ms. Braun's questions as well as other questions from the subcommittee might have regarding the budget. Regarding the funds appropriated to the Maryland Patient Safety Center, the $750,000 within MHCC budget to distribute to the Maryland Patient Safety Center for a public awareness campaign related to healthcare workforce violence has been fully expended. The funds supported a contract to develop the campaign, which included a website, digital ads across various social media and news platforms, and other statewide advertisements. To our knowledge, the campaign is currently running successfully and has been highly effective. Regarding the classification of registration surcharge revenues for shock trauma in fiscal year 25 and 26, the Department of Transportation and Department of Budget Management determined the allowance amounts for these two fiscal years based on estimates from the Emergency Fund Law, which took effect on July 1st, 2024. The figures in the Emergency Medical System Operation Fund, which is Appendix P, like Paul, represents estimates of the revenue to be distributed to Shock Trauma Center in fiscal year 25 and 26. It is important to note that unlike previous years, drivers can now register their vehicles for different time periods, annually or biannually, and can make payments throughout the payment plan, through a payment plan. As a result, it's challenging to accurately estimate the exact amount of revenue from motor vehicle registrations at this time. The Department of Budget and Management has confirmed they are working with Shock Trauma to ensure the budget aligns with Appendix P in the amount allotted. Regarding the integration of the trauma registry with other data sources, MIMS has been collaborating with CRISP to assess the feasibility of aligning the same encrypted patient identifier to entries in the Maryland Trauma Registry, similar to identifiers used in MHCC's All-Payer Claims database and the HSCRC's hospital dataset. Two issues are relevant. The first is ensuring that sufficient patient demographic information is provided to facilitate a valid match between trauma registry entries and CRISP's encrypted identifier. After several refinements, CRISP now believes it can assign the appropriate identifier to more than 90% of trauma registry cases. This year, MIMS plans to begin submitting trauma registry use cases quarterly to CRISP for the addition of the encrypted identifier. The second issue involves linking the encrypted identifier to the clinical data within each trauma registry entry, which requires adding a new field to MIMS proprietary software. In the coming months, MIMS will collaborate with its software vendor to identify the most reliable and cost-effective approach. Chair, Vice Chair Jones, and members of the subcommittee, this concludes my remarks. I'm happy to answer any questions you may have at this time.
Thank you so very much. I'm sorry. I'm not sure if I heard your name. Do I have
Mr.
you here?
Jones, my name is Andrew York, and I'm with the Prescription Drug Affordability Board. So we are a very small independent agency in this budgetary analysis, and we just wanted to be available to answer any questions.
Wonderful. Thank you so much. All right. Are there any questions from the committee? I have some. Well, oh, your light, I didn't see your light on. Go ahead, Mr. Ruff. Go ahead. No, I yield to you.
Okay. So we had talked a little bit about that. I believe one of my questions has been answered, and that was around DLS's question on the efficiency of the grant process, cost per student, and the differences between counties. So thank you for covering that. Those differences in costs were glaring. So thank you for going over that. If you turn to page 17.
You provided more insight, and I thank you for that, into shock trauma funding, questions for DLS, and that they had on 17 in the analysis. You mentioned that it's hard to quantify actual registration amounts received at this time. Did you go over a timeline or a team that's working with you to figure out how more accurately we can estimate the revenue source?
Thank you for that, Chair. Thank you for that question, Madam Chair. So I did not specify that. We do believe we will have that information later in the quarter, but we will follow up with you to make sure we can get you a more specific answer.
Okay, so Q2, later in Q2. Wait.
Yeah, actually, it would be
Q3.
it would be before the end of the fiscal year. We would have this information probably in the next 4 to 8 weeks, but I will confirm that to be certain of.
Okay, great. Wonderful. And then the Maryland Patient Safety Center. Is there any other organization in the state doing the work that the Maryland Patient Safety Center does?
So I would say, thank you again for that question, Vice Chair Jones. So they serve a unique role in the Patient Safety Center. They convene providers, families, patients, and they're innovators in patient safety, avoidable patient harm, if you will. So I think that there are a lot of organizations that aim to accomplish these kinds of goals, but not one that's really targeted as a mission and an organized group setting out to do this work. So they receive grant dollars, and their mission is very broad as it relates to patient safety and innovation in those patient safety approaches.
Okay, thank you. Mr. Ruff?
Thank you, Madam Chair. And thank you to the panel. My questions are to Mr. Crom. Can you hear me, Mr. Crom?
Oh, yes, sir.
Just making sure. Wanted to have a conversation, a series of questions. So I'll start with this question. You would agree that health equity improvement is imperative to providing a fair health care system for all Marylanders, correct?
Yes.
Okay. And you would agree that while the HSCRC model has made some strides in this area, sometimes it's not been centered on health equity improvements, correct?
So I would say that the all-payer system is something that has made significant impacts in equity of healthcare delivery, especially for acute care services. In large part, that's due to equalizing the costs, equalizing the payment, particularly for Medicaid and Medicare beneficiaries, which in other states is a major reason for disparities in access to acute care services. I think where we've got room to improve is in, but as a whole of the healthcare delivery system, room to improve in improving health outcomes, reducing disparities in health outcomes.
And you would agree that health outcomes is directly related to access to care, correct?
Yes.
Okay.
In some cases, but also social determinants. I mean, there's a range of factors that go into improving the health outcomes.
Okay. You would also have to agree that HSCRC's policies are supposed to be designed to support access to care in low-income communities, correct?
Yes, and I believe that, again, what I described, that mechanism has been particularly helpful for low-income communities.
Okay. And you would agree that at your 2024 workshop, you stated that HSCRC has to be more purposeful about tracking the direct impact on equity and must take more targeted action to support access to care for low-income communities, correct?
Yes, and we've been doing a lot of work to understand access and its and the distribution of resources across the state.
And you would also agree that equity and population health are the drivers of the AHEAD model, correct?
I'm sorry, say that again, sorry.
Equity and population health are the drivers of the AHEAD model.
I would say that those are major priorities, yes, of the AHEAD model.
Okay, so with all that said, let's talk about HSCRC's intersection with the Medicare Advantage program in Maryland. Would you agree that MAs offer supplemental benefits like dental, vision, and transportation primarily for low-income senior citizens that traditional Medicare fee-for-service does not cover?
Yes.
Okay. And you would agree that CMS pays MA plan providers a monthly premium to pay for hospital, dental, and doctor's bills, correct?
Yes.
Okay. You would also have to agree that the MA model in Maryland is not working because CMS, in their payment methodology, doesn't acknowledge the federal waiver that MAs have, and as a result, nearly all of the medical advantage plan providers have been losing money.
So I think that that's a little bit of a complicated answer. I would say that the federal kind of reimbursement model for Medicare Advantage does accommodate states with higher Medicare costs, of which Maryland is one, but it doesn't give Maryland a kind of special kind of reimbursement methodology for MA plans.
Okay. And so you would have to agree that because of these devastating losses that the MA plans have been taking over the years, MedStar, Aetna have all canceled their MA plans, correct?
They have canceled their MA plans or have shifted them, yes.
Yeah, some of them have reduced their service, correct?
Mm-hmm. Yes.
And this has caused serious disruption for vulnerable low-income seniors, correct?
I mean, I can't speak to that. We don't regulate the MA plans, but I'm aware that they have exited the market.
How many seniors are enrolled in Medicare Advantage in Maryland?
Again, I can work offline with agencies that do have that information. I don't have that.
Okay. Well, you would agree that in fiscal year 20, 21, and 22, your agency subsidized Medicare Advantage in the amount of $50 million a year, correct?
Yes.
But since then, you've ceased that subsidy, and the remaining MA plans are seriously contemplating leaving the market, correct?
We've heard from at least one plan that is contemplating exiting the market.
Okay. Well, you've also talked to, so are you referencing LifeBridge Health and Alterwood?
I'm not sure that we can say specifically because we are working with them on specific matters.
Okay. Well, yeah, I've talked to them as well because they provide the breadth of, or a majority of the healthcare in my district, in the 41st district. They've suffered losses in fiscal year 24 alone in the amount of $25 million. And I know that you're aware of that.
Yes.
I think they've also explained to you that if they have these same type of losses, that they are going to cancel their MA plan, right?
My understanding is that it wouldn't be sustainable for them to continue to lose at that rate.
Right.
Yeah.
And Alterwood services about 10,000 low-income seniors in Baltimore City and Baltimore County, nearly 80% of whom are African American.
Yes, I believe that's correct.
And so it's not your testimony today that cancellation of these plans will be disruptive and problematic for some of the most vulnerable members of our community, our elders?
I mean, it would certainly be disruptive for their members, yes. Yeah.
Okay. So why did you discontinue the marketplace stabilizing subsidy?
So it was intended to be a short-term solution. It was not intended to be an annual subsidy. So what we have done though is we actually just put out for public comments something that we've worked with CMMI on, our federal partners. And I will say our federal partners here are very, very important partners with respect to MA funding. We do need them to support any kind of long-term solutions here for MA reimbursement in Maryland. What we just put out for public comment is a program that would align or that would seek to align incentives for MA plans as well as with incentives for hospitals under the total cost of care model. And in particular, what it would incentivize MA plans to do is make investments to reduce the need for hospital utilization, which reduces costs, and then the MA plan would then share in that savings. So that is a program that we think, and I think CMMI at the time was interested as well, that would bolster a sustainable path forward for MA plans, but also incentivize reduced utilization that would depressurize hospitals. So that would create a kind of win-win situation. So we view that as a more sustainable path forward. However, there are a number of dependencies on CMMI approval in order to get that done. So that is out for public comment in terms of like how we would do that methodologically, but we will be able to come back to you with information and progress updates in the coming months.
Maybe we could, thank you so much, Mr. Crum. Maybe we could circle back because this does obviously need further discussing. Maybe we could do this offline and really dig in a little bit more, especially since some of these can't be answered yet.
Right, and I did hear you mention that in the Senate hearing last week about this idea, but I do think that there is a serious urgency around this issue. I would like to know whether even temporarily the subsidy can be reinstated so that the plans that are providing support to these low-income folks can continue. So I would very much like follow-up, just as you had promised to the Senate members of the Health Subcommittee over there, because this is a pretty serious issue for a lot of seniors in Northwest Baltimore and in Baltimore County, and we cannot permit that type of disruption to their health care services.
Happy to follow up.
Thank you.
Thank you, Mr. Ruff. Are there any other questions? No? Okay, thank you so very much. I appreciate it. I see Dr. Scalea, Thomas Scalea is in the back. Would love to have Dr. Scalea from the R. Adams Cowley Shock Trauma come on up. Hello, Dr. Scalea. As soon as you are ready, please proceed.
I guess now, good afternoon. Last year, the Maryland Trauma System and Shock Trauma, the only freestanding trauma hospital in the United States, were stressed to the max. Many of us spent countless hours discussing possible solutions, and in the end, the Maryland legislature again voted to support trauma care. Thank you. We now run, I've been asked to comment on how shock trauma utilized the additional appropriations. You will remember that the issue was access to care, and I'm pleased to say we've done well. We now run 8 operating rooms, not 6. This has led to a marked increase in the number of operative cases we are able to perform. This has translated to a decrease of over 2 days in patients requiring operative care. A reduction of 2 days is huge. This reduces the risk of hospital-acquired infection and allows us to get more patients in the building. We have then been able to reduce lost inter-hospital transfers by over 2/3. We continue to improve, and I would estimate we now lose 1 or 2 per month on a bad month. We've also markedly decreased the amount of time we spend on capacity alert. Capacity alert is not trauma bypass, and I can explain that more if you would like. In 2023, in many months, we were on capacity alert approximately 5% of the time. That's the threshold allowed by MIMS. Last month, we were down to 0.2%. The front door is, in fact, wide open. We have significantly expanded our programmatic services and training, including a greater than 300% increase in the number of people receiving Stop the Bleed training and a 7% increase in the number enrolled in the violence intervention program compared to 2024. Approximately 150 patients received services through the Intimate Partner Violence Program, and we launched a new program, Saving Maryland At-Risk Teens, the SMART program, which is a free 6-week educational course that equips these children with skills in handling conflicts to reduce community and violence in Baltimore youth aged 13 to 21. For over 50 years, the Maryland legislature has continuously voted to support the finest care in the world, and last year was an important step to maintain that level of quality. I believe we've spent these funds wisely, and I thank you for your past, current, and future support for trauma care in Maryland.
Thank you so much, Dr. Scalea, and I can't thank you enough on behalf of the state of Maryland. We do have the finest care. And it's so much of it is what you do in your hospital, and we are forever grateful to you. Does any of the committee have questions? We only have thanks for you, sir. Thank you so very much.
Thank you.
Good to see you.
Good to see all of you.
All right. We will now go to, sorry about that. Looks like we will go to Ann Geeds, Mental Health Association of Maryland. And we have enough seats, we can do 4 at a time. And as soon as you are up there, you can start. Andrew York, Maryland Prescription Drug Affordability, oh, we had him. Kathy Hedge, Parent Encouragement Program, PEEP, and Richard Proctor. And whenever you're ready, please begin.
Thank you, Madam Chair and committee members. My name is Ann Geddes with the Mental Health Association here in support of full funding for the consortium, the commission, the Community Health Resources Commission, and the Consortium on Coordinated Community Supports. I know you know 2020, the blueprint established $130 million a year, FY25 going forward for consortium grantees. Now is not the time to cut that funding, and I just want to cite one data point. In the 2022-2023 Youth Risk Behavior Survey, 28% of Maryland high school students said that their mental health was not good most of the time or always, and 24% of middle school students said that they had seriously considered suicide. We have a crisis on our hands, and we need full funding for school behavioral health services. It was earlier mentioned how successful the consortium grantees have been. They've served, in 6 months, they served 58,000 kids. Since then, they've served more. 70 to 80% show marked improvement in their behavioral health functioning and 90% satisfaction rates. So the impact is very profound. And again, the BRFA cut would have a devastating effect on programs that have already been established. They've hired staff. They've made close working relationships with school staff. This would just set all those programs way back, shut most of them down. So, we're asking for full funding for the consortium, and I was just want to add, you see my button, there are a lot of people here, some of them had to go over for the BHA hearing, really to resist cuts to behavioral health this year. So that's why we're here. Thank you for your time.
Good afternoon, Madam Chair and members of the committee. I'm Kathy Hedge. I'm the Executive Director of the Parent Encouragement Program. We're better known as PEP. We are a consortium grantee, and I wanted to give you a flavor of what an organization like ours that is funded by this program, what we're doing, and what the cuts would mean to our organization and the families we serve. So I'm here to speak in favor of full funding for the Consortium on Coordinated Community Supports. We work in Montgomery County, Howard County, Frederick County, and Dorchester County. And what our organization does, and we've been around for 42 years, we hold support group style classes for parents and caregivers to give parents and caregivers approaches for how they can build a strong relationship with their child and strategies that they can use to help build their child's resilience, self-motivation, and self-confidence. So far, with consortium funding, since March, we've served 2,200 Maryland children in 226 schools. And I will tell you, those are children that we would not have been otherwise able to serve. We staffed up with consortium funding, hiring staff and expanding our programs. If this funding were cut, I'd have to go right back and cut my staff and stop these programs. This was not a shift of funding. These are new programs created. And we are in the midst of a children's mental health crisis and a parent's mental health crisis. I see parents every day who are struggling. And I was a struggling parent myself that used our programs and saw the difference it made. We partner with NORC at the University of Chicago to measure results of our programs, and I will tell you that the participating families are reporting large improvements. They are saying they have better communication with their children, there is less yelling, there's more cooperation in the home, parents have a better sense of how to help their children deal with stress and deal with schoolwork, and there's an overall decrease in parental stress and worry. I was in Dorchester County a month ago, and I was speaking with a parent who had gone through our program. She told me that before taking our program, she was having fights with her kids every day. Her middle schooler was trying to run away, and she was calling the mobile crisis team 2 to 3 times a week. And after taking our program, and this is exactly what she said to me, I've not had to call the mobile crisis team once. And that she had taken our program 6 months ago. So this is not a cost, this is a cost savings, a net cost savings to our state. And I really urge you all to consider full funding. Yeah, that's all. Thank you.
Questions for this panel? No? Thank you so very much. Last call for Richard Proctor.
I'm sorry, I'm with the Maryland Healthcare Committee.
Oh, okay, you're good. All right, great. Tracy DeShields. Yep, there we go. Catherine Smith-Meyer. Is Catherine Smith-Meyer here?
Yes, I'm here.
Okay, great. And Beth Ann Dorman. And Stephanie Pedito. Can have a seat. And Raya Gupta.
May I begin?
Yes.
Good afternoon. My name is Catherine Smith-Meyer. I'm a clinical psychologist and the director of Chesapeake Bay Psychological Services. It's an outpatient mental health practice on the Eastern Shore, and I'm here to speak in support of full funding for the Consortium on Coordinated Community Supports. With that funding, we started a program, developed a program to provide therapy to students in our local schools, something we could not afford to do before. The only reason that we are able to recruit therapists and send them into the local schools is with the support of this funding. The funding helps bridge the gap between what insurance covers on one hand and versus, the actual work and time that's needed to provide quality mental health care services in the schools. The children that we're serving, I just want to be clear, would not have been served otherwise. They would not have ended up in our office, our traditional office setting, for a number of reasons. Some of those barriers are they're underinsured or they're uninsured. Their parents can't miss work to drive them to therapy once a week. Their parents can't afford the sky-high deductibles or the high co-pays that some of them have. Their parents can't afford childcare for the younger children while they're bringing an older child to therapy. And a lot of the parents are dealing with their own mental health issues, substance use issues, or chronic, medical conditions or disabilities that prevent them from being able to manage this kind of thing, getting their child to therapy once a week. Our school-based therapists that we've hired with these funds are treating children in the schools for conditions ranging from ADHD to bipolar disorder to post-traumatic stress disorder. Some of the symptoms that they're treating them for include, depression, cutting themselves, thinking about suicide. We're treating problem behaviors that range from running away, threatening to bring a gun to school. So I know my time is up. Thank you. Thank you.
Thank you. Good afternoon. Thank you for the opportunity to just testify. I'm Stephanie Pedito. I'm the recently appointed president and CEO of the Maryland Patient Safety Center. And I strongly urge you to fully fund the Maryland Patient Safety Center and add back the $1 million of funding that flows through the Maryland Healthcare Commission on page 80. Maryland Patient Safety Center is a national leader in patient safety, working with Maryland hospitals, nursing homes, and providers to reduce preventable harm, lower healthcare costs, and improve outcomes. We save lives and we save money. But the proposed budget cuts change puts this life-saving work at risk, threatening programs that prevent sepsis deaths, falls, medication errors, severe maternal complications, all of which drive up Medicaid costs, and each have a significant health equity component in that people of color, people with disabilities, older people, and people with language barriers have disproportionately higher harm. Medicaid is one of the biggest payers of preventable harm. Sepsis accounts for over 30% of hospital deaths and costs Maryland billions. Maryland Patient Safety Center's programs help prevent these infections, and we also supported implementation of Lauchlin's Law for identification and treatment of sepsis in urgent care centers for kids. And falls among older adults, as another example, result in costly hospitalizations, rehabilitation, and long-term care stays, many of which could be avoided. Severe maternal complications disproportionately affecting Black women and Medicaid-covered births lead to emergency interventions and lifelong health issues for mothers and babies. Without stable funding, these programs and the cost savings they generate are at risk. Additionally, this threat cuttens Maryland's healthcare workforce. Preventable harm contributes to burnout, moral injury, and workforce shortages. We equip providers with tools to improve patient safety, reduce errors and stress, and workforce turnover. At this time, when healthcare workers are already stretched thin, we can't afford to lose this support. Patient safety is not optional. It's a public health and fiscal responsibility. Please protect our funding and ensure Maryland remains a leader in safe, high-quality care. Thank you.
Thank you. Go ahead. Yeah.
Good afternoon, Vice Chair Jones and members of the committee. My name is Ria Gupta. I am the Interim Executive Director of Strong Schools Maryland, and I'm here today to urge you to restore full funding to the Consortium on Coordinated Community Supports. Maryland, as you heard, is in a youth mental health crisis. Research shows that 1 in 6 youth struggle with mental illness, yet fewer than 20% receive adequate treatment. These aren't just statistics, they represent students struggling, falling behind, and lacking the support that they need. And you again heard this, but the consortium was created to change that. In just 8 months, it has had outcomes. 58,000 students were served in 80% of Maryland schools, and they're set to serve 150,000 students by June, within the span of 1 year, in their first year of full functioning. This means that students are finally starting to receive the care they need, and schools are becoming better equipped to support them. And I really want to emphasize this. Despite its success, the proposed budget slashes consortium funding from $130 million to $40 million, not just this year, but indefinitely. That's a 70% cut in vital services at a time when demand has never been higher. Students will lose critical access to mental health supports, and this just off the ground program will have significantly less impact and reach. I know that the state faces a fiscal shortfall, but the simple truth is that this budget asks students to bear a huge disproportionate share of fiscal pain. Investing in behavioral health services improves academic outcomes, reduces disciplinary issues, and saves money in healthcare and public safety in the long term. We urge this committee to restore the consortium's full $130 million funding for fiscal year 26 and beyond. Our students cannot afford these cuts. Thank you, and I'm happy to take questions.
Thank you so very much. Does anyone have questions for this panel? Okay, thank you so much for your testimony.
Thank you.
Last call for Beth Ann Dorman. Beth Ann Dorman.
She had to go to the DHA.
Okay. Morgan Mills with Horizon Foundation.
Just me? Awesome.
Yes, that concludes my list.
All right, awesome.
Thank you. You have 2 minutes.
Thank you so much. Vice Chair Jones and distinguished members of this subcommittee, my name is Morgan Mills with Compass Advocacy, here today on behalf of the Horizon Foundation. The Horizon Foundation is Howard County's community health foundation and the largest independent health philanthropy in Maryland. Here today to urge you to fully restore funding to the Consortium on Coordinated Community Supports. As you've heard, the consortium was a part of the Blueprint for Maryland's Future, which was a historic investment in our children. The Horizon Foundation is a proud participant of the Howard County Community Supports Partnership Hub. There are 12 of these hubs across the state that are set up through the consortium, and the hubs address local needs in different environments across the state, providing an opportunity to deliver comprehensive behavioral health services for students and act as a central point of collaboration between providers, schools, and families. After several delays, the consortium has just come operational this past year. In the first several months of implementation, we've seen the consortium serve over 58,000 students across 80% of Maryland schools, and 475 new behavioral health workforce members were hired to deliver these services. I cannot overstate how critical this program is to addressing the growing mental health needs of our children and youth across our state. In Howard County, 30% of middle schoolers report feeling sad or hopeless. Our Black and Latino girls and our LGBTQIA+ children and youth experience the highest rate of mental health challenges, including depression and suicidal ideation. We need them to feel better so they can be ready to learn. Cutting services now means problems will get worse and children and families will suffer. In Howard County, we're working to increase access to culturally diverse and affirming providers, provide more peer support for youth and parents, and expand substance use prevention and intervention. Now is the time to lean in and provide more support for our most vulnerable populations, not less, and for that reason, we are urging the committee to reject the proposed cuts and fully restore the funding. Thank you.
Thank you so very much. Does anyone have a question for this panel? Thank you.
All right.
Okay,
Thank you so much.
That concludes our hearing, and we're going to move on to DHS Child Support Administration. So, Natalie, when you are ready, we are ready. Thank you.
Thank you, Madam Chair. Good afternoon. I am Natalie Andrade. I'm here with the Department of Legislative Services to present the fiscal 26 allowance for the Department of Human Services Child Support Administration. On page 1 of the analysis, you will see that the fiscal 26 budget increases by 7.7 million or 7.6%, bringing the total to $109.4 million. On page 3, Exhibit 1 shows a breakdown of the fiscal 26 budget. As you can see, personal expenses account for the largest share, that is 59% of the fiscal 26 allowance, primarily supporting local child support offices. About 18% or $20.1 million is allocated to cooperative reimbursement agreement with the state attorney's office, magistrate office, and sheriff's office, covering the federal share of child support enforcement activities, while the state share is provided separately. In Baltimore City, child support services are contracted to a private entity with $7.9 million allocated for this purpose. On page 4, Exhibit 2 shows the key changes in the budget. As you can see, the $7.7 million increase from the fiscal 25 working appropriation to the fiscal 26 allowance is primarily due to a $5.5 million rise in cooperative reimbursement agreements, aligning the budget with expected costs. The fiscal 25 appropriation appears lower because some contract expenses were prepaid in fiscal 24. Additionally, $196,597 of the increase is attributed to adding the Allegheny County Magistrate's contract. Salary increases also contribute to the overall growth. On pages 5 and 6 begins the discussion of the Child Reinvestment Fund, which is composed of federal incentive payments based on performance measures set by the U.S. Department of Health and Human Services. Exhibit 3 on page 6 shows that this fund has seen steady revenue and expenditure growth through the fiscal 24. Revenues increased from $9.1 million in fiscal 2018 to a peak of $20.4 million in fiscal 23, while expenditures also rose, reaching $20.7 million in fiscal 24. Furthermore, DHS projects revenues of $11.5 million in fiscal 25 and $11.4 million in fiscal 26, as outlined in the governor's fiscal 26 budget books. DHS should comment on the projected decline in revenues for fiscal 25 and fiscal 26 compared to the peak in fiscal 23. Specifically, DHS should explain whether this decrease is due to changes in federal reimbursements, lower collections, policy shifts, or other factors impacting the fund's revenue streams. Although revenue from the Child Support Reinvestment Fund was anticipated, the fiscal 25 budget did not include these funds. While using them could preclude federal reimbursement, not using them increases overall state spending. The fiscal 25 budget bill reduced $10.75 million in the Child Support State Program, assuming these funds could be used, and authorized a budget amendment to replace the reduction with special funds. However, DHS has not processed this amendment. For the second year in a row, the fiscal 26 budget also omits these funds with no backfill from general funds. DHS acknowledged the omission and is working with the Department of Budget and Management to resolve it. DHS should provide an explanation for not processing the amendment and clarify the impact of this omission on the program's operations and funding levels. On page 7, the personnel section detailed a reduction in turnover expectancy from 11.03% to 9.08%, with 54.6 vacant positions as of December 31st, 2024. While recruitment efforts have been made, 6 positions remain vacant for over a year. On page 8, the key observation section begins with a discussion of the child support performance measures. The 2024 JCR required DHS to submit 3 reports on statewide and local performance for 4 federal incentive goals, but DHS has only submitted 1, limiting the analysis presented in this section. Additionally, DHS did not include actual federal fiscal 24 data in its managing for results submission, further restricting the availability of performance data. Exhibit 4 on page 8 shows that as of June in federal fiscal 24, statewide performance remained stable for cases with support orders, but declined in current support collections by 1.97 percentage points. Paternity establishment and arrears collections saw a slight increases of 0.74 and 0.57 percentage points, respectively. However, none of these metrics met the state's fiscal 24 goals. DHS should provide updated and accurate performance measures as of December 24 to ensure a comprehensive understanding of statewide and local progress toward federal incentive goals. Given that only one of the 3 requested reports has been submitted, and MFR measures, which are all federally required performance metrics, were not reported in the actual figures, DHS should also clarify its plans to meet reporting requirements and address any barriers to timely data submission. Issue number 2 on page 9 presents an update of the driver's license suspension amnesty program. In August 24, CSA launched the driver's license suspension amnesty program to help non-custodial parents resolve license suspensions related to child support. Participants could meet with caseworkers to arrange payments, modify orders, or enroll in employment programs. If approved, they receive a compliance letter for the Motor Vehicle Administration to reinstate their license at no extra cost. Between January and August 24, 21,563 non-custodial parents were eligible, but only 1,127 participated, that is 5.2%. These participants collectively owed $283.5 million in child support, with an average arrears balance of $13,147 per non-custodial parent. However, only $594,737 was collected, that is 0.2% of total arrears, and just 19% of participants made full or partial payments. The program also led to 106 modification requests, indicated some non-custodial parents sought long-term adjustments. Despite low participation and minimal financial impact, the program effectively reinstated driving privileges, with MVA issuing compliance letters to all the 1,127 participants. However, given the larger number of eligible non-custodial parents who did not participate, DHS should comment on any barriers to participation and explore strategies to enhance outreach and effectiveness in future amnesty programs. To conclude, on page 10, DLS recommendation is to adopt committee narrative requesting 3 child support performance reports. And with that, I conclude my presentation and happy to take any questions.
Thank you so very much. Does anyone have a question for DLS? No? Okay, thank you so very much. Executive Director, is Kevin here?
Kevin no longer is with us. It's myself and my team.
Well, please come on up. Thank you so very much. Thank you so much. And you can proceed as soon as you are ready.
No worries. Good afternoon. Good afternoon, Co-Chair Jones and members of the committee. For the record, I'm Carnitra White, and I serve as the Principal Deputy Secretary for the Department of Human Services. We're grateful for Ms. Andrade for her analysis, and with me at the table, I have the Executive Director for our Child Support Administration, Mrs. Janice Johnson, and I have the Acting Financial Chief Executive, Ms. Jessica Smith, with me. You have our written testimony, so I'm just going to highlight a few items, and then we'll just go right into the issues for from the analysis. The Maryland Child Support Administration works with parents to provide the financial, medical, and emotional support their children need to grow and thrive. In federal fiscal year 2024, CSA served over 150,000 families and collected and distributed over $482 million in child support payments. Families previously participating in temporary cash assistance took home $71 million last federal fiscal year, providing a base level of financial stability for children. This year, we will celebrate the 50th anniversary of the Title IV-D Child Support Program. The purpose and function of child support programs have evolved since they were first authorized in 1975. Our work through the Child Support Administration is meant to invest in and support families and not to punish them when they're trying to make ends meet. We utilize the tools at our disposal as engagement tools to facilitate parental support and work to support those who are unable to pay. For example, in August 2024, we hosted our first statewide driver's license suspension amnesty program since COVID. This event led to the reinstatement of over 1,000 driver's licenses and the collection of nearly $600,000. We administratively exempt parents from driver's license suspension program when they have a wage attachment in place, even if the full obligation has not been met. We're taking a holistic view of the family and supporting non-custodial parents who intend to provide child support but who are unable to do so. We will continue to develop new methods to increase engagement and assist non-custodial parents with providing support for their children. In 2025, we plan to host a series of statewide activities that will include expungement and resource fairs for both custodial and non-custodial parents. We will work to increase education and enrollment in our parent incentive program to help non-custodial parents reduce their state-owed arrearages. And we will continue to work with our community-based partners to assist non-custodial parents who need job skills and employment opportunities to financially and emotionally support their children. We're committed to creating a more equitable child support program to strengthen families and ensure children have the support they need and deserve from both of their parents. We thank you for your support, and now we'll turn to the DLS analysis, and my colleague Jessica Smith will address the first two issues.
In response to the analysis of the projected deadline in Child Support Reinvestment Fund revenues, a portion of the Child Support Reinvestment Fund was inadvertently omitted from the fiscal 2025 budget and proposed fiscal 2026 budget. We request that the fiscal year 2025 appropriation and fiscal year 2026 allowance be restored to the fiscal 2025 target, totaling $20,050,163 to align with the current revenue projections. In regards to the response from the analysis, not processing the budget amendment to replace general funds with special funds from the Child Support Reinvestment Fund. The Child Support Administration is federally mandated to provide services supported by the Child Support Reinvestment Fund and will continue to do so in order to support the families we serve. The appropriation for this purpose was inadvertently omitted from the fiscal 2025 and fiscal 2026 budgets. We are working with the Department of Budget and Management to address this omission via the appropriate budget corrective vehicles. Now I'll turn it over to Janice Johnson to address the remaining responses.
Good afternoon, Madam Chair and committee members. To address the performance measures of the two overdue report, the September of 2024 performance report, it was submitted February 21st of 2025. The December 2024 performance report was submitted on February 22nd of this year. And we will work with Department of Budget and Management to update our MFR measures. In our written testimony, you can find the latest performance data for federal fiscal year 2024 and the first quarter of the federal fiscal year. We are happy to report that we met 2 of the 4 performance goals: paternity establishment and current collections. As we have discussed at the previous DHS budget hearings, over the last year, we renewed our focus on ensuring that our public-facing data is consistent, validated, and comprehensive. We are committed to transparently sharing high-quality data with our partners, and we will continue to enhance our ability to do so. In response to barriers to non-custodial parents participating in the amnesty program, past amnesty programs, including our 2024 program, have had 2 principal barriers. Some non-custodial parents fear engaging with the local child support office due to the perception of arrest or other harm, and we may not have the last known address for a non-custodial parent. We are addressing the first 2 barriers with public outreach campaigns and working with community-based organizations to decrease fear. For contact information, we've focused on updating our contact information as we receive new information, such as through return mail, court updates, and other locate resources. We are diversifying the way we communicate with our customers to provide notification via email, text, and through consumer portal. In the response to the child support performance reports, we concur, but request an adjustment to the report due dates so that we can receive the relevant information and analyze the data. The requested dates are included in our written testimony.
So with that, Madam Chair, that ends our testimony. I'd like to once again thank the committee. This is our last time of 6 of being before you all. So I would like to thank you all for your continued support and you're holding us accountable in these budget hearings, but also the respect that you all have for the work that we do. So thank you so much.
Well, thank you.
You all have been wonderful to work with, and we appreciate the work that you are doing. Does anyone have a question for this panel? Mr. Ruff?
Thank you, Madam Chair. I have a series of questions. No, I'm just kidding. I just wanted to echo the comments of Madam Chair. I know you guys have been before us a lot, and you have a lot of hats to wear. We appreciate all your efforts, and we will continue to support them as well.
Thank you.
Thank you.
Okay. Thank you again for everything, and we'll be in touch, obviously. We'll constant communication, but thank you. And with that, that concludes our hearing.
Thank you all.